Thank you, Pepe. Next, please welcome Dr. Leann Birch, who will be discussing modifiable factors related to responsive feeding. Dr. Birch is the William P. Flatt Professor in the Department of Foods and Nutrition at the University of Georgia. Her research is focused on individual and contextual factors that influence the developing controls of food intake and obesity risk among infants, children, and adolescents. Please welcome Dr. Birch.
Thanks, Brent. It's great to be here. Thanks for inviting me, those of you who've been organizing this event. I'm going to talk a bit about not what kids are fed, but how they're fed, and more broadly about parent-child interactions and how those might be related to obesity risk. Put things in context historically. I'd like to just say that I think throughout history, for most of history, the threat has been different than the current threat to child health with respect to weight status. Is that food scarcity was the context in which parenting behaviors developed. And those included things like high risk of child mortality, morbidity, because there was not enough food around, food availability was unpredictable, food choice was limited, palatability was low, energy density and nutrient density were also low in terms of the foods that were available, and there are still many people in the world who are living in this situation. And I think these traditional parenting practices are still our kind of default in many cases. You know, they've been around for a long time. It's what you do. You don't think about them. That makes it easy to continue to do those things. So some of those include feeding being the default response to infant crying, no matter what the reason is. Try to get children to eat large portions, to finish what's on their plate, to eat when they say they're not hungry or aren't hungry. This notion that a big baby is a healthy baby, I think, is part of the expectation that parents have. And as I say, these persist. And the problem is, in the current obesogenic environment, they may place kids at risk for rapid weight gain and increased obesity risk. Rapid weight gain in infancy, as many of you know, is problematic because we know that it predicts higher BMI and fat mass in childhood, increased risk of obesity in adulthood, higher blood pressure and in both childhood and adulthood, and increased metabolic risk factors. So there are a lot of reasons that we should be focused on weight gain in infancy. And I think that the evidence on early rapid weight gain predicting later poor health outcomes is pretty clear. The real question is, what affects rapid weight gain, and can we do something about it? One potential way to go is to really try to change these defaults, these traditional feeding practices, using what's been called responsive parenting. And this concept of responsive parenting has been around for a long time in the developmental literature. And it really has to do with responding in ways that are prompt, contingent, developmentally appropriate, and that this is supposed to be a good thing because it fosters the development of self-regulation. The infant begins to learn that the world is a predictable place in which their actions have an effect, and that can lead to the emergence of regulatory processes. It's a pretty simple kind of process, really. It involves observing the infant's behavior, interpreting that behavior, and then acting upon it. Now, the question for today is, can responsive parenting affect rapid weight gain and obesity risk really early in life? And you'll see the evidence is scant. I think a first step in moving forward here is to say, first of all, can we teach parents about responsive parenting? And there's a fair amount of evidence that yes, this can be done. I picked just one piece of evidence from Susan Landry's work showing change in mothers' responsiveness as a function of an RCT that they did, where this is just a measure of, contingent responding over time, and it increased in the treatment group as compared to the control. So you can change maternal behaviors. We also know that responsive parenting in other domains of development has a lot of positive effects. This is, again, just another slide that gives one example of many of the effects of maternal responsiveness on cognitive and language scores. You see effects on socio-emotional development and other things as well, but you can see, again, that compared to low responsiveness, kids who come from families where mothers are highly responsive have better language, cognitive developmental skills. The general idea about what might be going on here, as I've already mentioned, is that self-regulation then affects cognitive, social, and emotional development. And self-regulation involves a number of overlapping constructs. Includes things like self-control, willpower, effortful control, delay of gratification. Here you see a kid struggling with the marshmallow task there. Emotion regulation, executive function, inhibitory control, a lot of which are measured in different kinds of ways. And I think it's quite possible that multiple aspects of self-regulation, such as the ones I just mentioned, are pretty important in avoiding excessive intake in the context of our current food environment. So, can teaching responsive parenting reduce obesity risk? My colleague, Ian Paul, who's here to help me out today, and I, for a number of years now, have been trying to look at this question. We've have two RCTs, one of which is completed, the other which is still in process, looking at this question of whether responsive parenting can reduce obesity risk. These RCTs have been with first-time mothers and infants. We chose to use first-time mothers because we don't have to change their behaviors. We just have to help them not use those traditional behaviors. Their primary outcomes in those studies have included weight gain in infancy and weight status in slim time at 1 year, and in Insight, we're following kids to 3 years. Secondary outcomes, we're interested in parenting behaviors, whether we can change things like sleep duration, night feedings, the use of feeding to soothe, which would be the indiscriminate use of feeding regardless of the cause of distress, finishing the bottle, and looking at whether we can see some evidence of emotion regulation differences between treatment and control. So here's just this sort of simple conceptual model about what we think might be going on, which is if you can affect responsive parenting, you can probably affect self-regulation and infant sleeping, fussing, and feeding behaviors, which should in turn be reflected in these outcome measures. All right, the first thing that we were able to see in terms of mothers' behaviors, or one of the things, was that mothers in the intervention group in slim time were less likely to report encouraging their infants to finish the bottle. Although if you look at this, you'll see that even in the intervention group, half the mothers were still encouraging infants to finish the bottle. The second thing I want to talk about is that we did see some differences in early self-regulation. You begin to see emotion regulation emerging around the end of the first year of life. This was in a task where infants were engaged with their mothers with a toy, pretty attractive toy, and they play with it for a little while, and the mother picks up the toy and turns around and walks away and leaves the infant without the toy. The infant typically gets upset, and what we're looking for is how well the infant can regulate their emotions and calm down during that period. And what we see, and this is coding from videotapes, that in fact you do see some evidence that the kids who've been in the intervention group are learning some self-soothing behaviors. And it's probably related to some of the differences that we see here in terms of nighttime feedings, how many times babies were fed in the middle of the night. You see that there are fewer feedings in the intervention group than the control. And one of the nicer things for parents, too, is that these kids were actually sleeping a bit longer at night. Again, we think it might be because they're learning to self-soothe, to calm themselves down, to settle and not elicit the parent to give them a feeding. With respect to the primary outcome in slim time, we did see differences in infants' weight for length percentiles at 1 year, with the lowest being among the children who had both interventions. I didn't tell you, but I think I showed you in the slide, it was a 2-by-2 design so that infants and parents received either neither intervention, one that was really more focused on appropriate introduction and timing of solids, soothing and sleeping, or both. So it took both of those things to really move the needle on weight for length percentiles at 1 year. In the current ongoing trial, we now have complete data through 1 year, and I'm going to give you a preview on some of that in a minute, but we really focused more on responsive parenting broadly, talking not just about feeding, but about helping your baby to sleep longer, how to deal with a fussy baby, what to do with your babies when they're awake and alert, and on really just responsiveness in all those different contexts. Okay, so here are some data. These are just the actual data. That's why there are no error bars. It's just a frequency distribution of the percent of infants that are showing differences in weight gain. We've used this conditional weight gain score that Tim Cole and company developed years back. Basically, it has a mean of 0, so you're either above or below the mean in your weight gain, in this case from birth to 28 weeks. And what you see is the distribution of scores for the intervention group is shifted to the left relative to the control group. Okay, so they have a slightly lower weight gain over that time. To look at the data slightly differently, about 50% of the infants in the control group are above 0, and 50% are below, as you would expect. In the case of the treatment group, we see 37% who are above the mean of 0 relative to 50% in the treatment. In the control group. What about weight? Here we go. What about weight at 1 year? This is weight for length percentiles. Again, this is just a frequency distribution. What you see again is something that looks similar in the sense that you have the treatment group shifted to the left. The parenting intervention babies have slightly lower weight for length percentiles relative to the control group in gray. And those distributions are significantly different from each other. In addition, we find in general that kids who are above this conditional weight gain score that I showed you a moment ago, that are above 0, are 6 times more likely to be over the 95th percentile at weight for length at 1 year. Okay. So what do we know so far? Well, again, it's early days, but it looks like, at least from our own work, that responsive parenting can move the needle on early rapid weight gain. It looks like we're having effects on weight for length at 1 year. Whether we'll have longer-term effects still remain to be seen. But we certainly saw less feeding to soothe and less bottle emptying on the part of mothers, longer night sleep durations, and fewer night feedings, more self-soothing, some regulation of negative emotion that was greater in the treatment group, and, as I said already, effects on rapid weight gain and weight status at 1 year. There's a lot of gaps, a lot of things we don't know. One thing that's intriguing about this approach is, given the other data that we have out there on the positive effects of responsive parenting, whether we might be seeing some collateral benefits on other aspects of children's development, in addition to any effects that we might see on growth and weight gain. Will these findings be generalizable to higher risk samples? We simply don't know. I should also say that we did use first-time parents in all of this research, and it's quite different to establish new behaviors than it is to try to change existing behaviors with multiparous mothers, of course. In the INSIGHT trial, we've also included formula feeding mothers as well as intent to breastfeed mothers, which were the participants in the first Slim Time trial. And we see similar effects for both formula-fed and breastfed infants. So we still have a lot of more data to analyze, but at this point it looks like the effects aren't limited to intent to breastfeed mothers. What about dose? What about timing? We started very early. We were intervening before the end of the first month of life, and I think that was probably important. We used home visits done by research nurses. I think this is an approach that's expensive and likely not to be scalable, so we don't really know if there are other modes of delivery that might work. And we have no data yet on long-term effects. Thank you very much.